Live from the Washington, D.C. area, it's the Inside Scoop. All the news that our viewers want to know. Now, here's the host.
Welcome to Inside Scoop. I'm your host, Catherine Reed, and joining me tonight is Dr. Lora Vece. She is a nurse practitioner, and she is here to talk about a bill, HB 793, on behalf of the Virginia Council of Nurse Practitioners. Thank you so much for being here, Lora.
Thank you, and thank you for having us.
Well, I'm very interested. I've done shows previously on Inside Scoop about nurse practitioners. This is not the first time that this bill has actually come up before in the legislature. But tell us a little bit about why you're seeking legislation that changes the way in which nurse practitioners can deliver health care services.
Well, the short answer to that is improving patient access to care, decreasing cost, and having nurse practitioner care be available to anyone who needs to be seen for health care. Right now in Virginia, we have a practice agreement requirement where we have to have a collaborating physician who's actually signed a sheet of paper for us in order for us to practice in the state. And if you don't have a collaborative agreement, even if you are experienced, even if you are board certified, even if you have seen patients for years, you cannot practice in the state of Virginia.
And this has impacted you directly. You have been in a situation where, and you know, your nurse practitioners have the same medical training, pretty much. Explain a little bit about all of the training nurse practitioners go through in order to become a nurse practitioner.
Okay, well, first of all, in order to get into a nurse practitioner program, you have to be an experienced nurse. You have to have finished your bachelor's degree or your associates and bachelor's are being with that, and you have to have experience to apply to the programs. When you get into the program, and it's either a doctorate or a master's degree program, and you are required to take advanced physiology, you're required to take advanced pharmacology, advanced health assessment classes, as well as the application classes where you're working on case studies and medical application of the knowledge, and decision making, so that you're looking at the different perspective as a provider instead of as someone who is seeing patients at a bedside or taking care of patients just as a nurse. And you go through all those classes before you get into your clinical. While you're in clinical, you're seeing patients in a specific specialty. So all of your master's and doctorate clinical practice is in the area of your specialty. For me, that was a family nurse practitioner. For some, it's a pediatric nurse practitioner. For others, it might be an acute care nurse practitioner. There's multiple different avenues there. And so all of your clinical hours as a nurse practitioner then, while you're in school, are spent in that one specialty that you will actually be seeing patients in. So unlike physicians who are in medical school and that's their generalist, they've never seen a patient before, they've never taken a blood pressure before, and all that's done in med school. That was done in our undergraduate degree. What we are doing in our graduate degree is really focusing on the care we're going to be providing as nurse practitioners.
And hasn't this really become a necessity because of the need to provide better primary care?
One of the real issues in this country as a whole is the shortage of primary care providers. And the Institute of Medicine came out with a report several years back that said we need to unencumber the restrictions on nurse practitioners, that they are a primary source of providers who can fill that gap. And one of the things you will find is that most nurse practitioners go into primary care versus physicians where it's a small percentage. There's a lot of financial reasons for that, especially with physicians and the debt they come out with in medical school. But in terms of meeting the needs of primary care in this country and in the state of Virginia, nurse practitioners really hold the key to being able to meet the needs of care for our patients, for our neighbors, to access the care they need for health care.
So there has been, I'm assuming, in recent years, more and more people, men and women, who've gone into the program to become nurse practitioner because there's an overwhelming need. And to your point, a lot of physicians go into specialties. They don't necessarily become general practitioners like what I had in 1965, right? Where you had a neighborhood GP and everybody in the family went there, and that was the model of medicine. That's really not the model of medicine anymore. You have specialists, and then you have the need for a lot more primary care, and that's everything from wellness visits to chronic disease management.
Yes, so when we're talking about primary care, we're talking about wellness, we're talking about, getting your cancer screenings, talking about diet and exercise, looking at your cholesterol. What are your individual needs related to your past medical history, your family history, and making sure those are met. We're also talking about chronic disease management, whether that's diabetes, hypertension, heart failure, other chronic diseases, as well as the acute needs. You come in with a urinary tract infection, you have a sinus infection, you have pneumonia, all of those things that are normally done through a primary care office that we really want to keep in primary care and not end up within the emergency room.
Right, because there's been, I think, a lot more people are aware. Obamacare has been, or it was actually the ACA, the Affordable Care Act. We should not call it Obamacare. It's the Affordable Care Act. But it raised people's awareness about the cost of providing health care relative to the outcomes. And the fact that we need to be more focused on the outcomes and less about, simply paying for visits and checking off the box without asking, what are we getting for the money we're spending on healthcare? So I think a lot more people in this debate that has raged now for, it's coming on 10 years, about the fact that we need to look at outcomes and we need healthcare that correlate with good outcomes for the money that we're spending.
Exactly.
And so I'm assuming that probably a lot more people are choosing to go into the profession of nurse practitioner rather than simply being a clinical nurse, or for that matter, people who decided to become physicians, because there is a niche and there is a demand for this niche.
Okay, I do know that right now the nurse practitioner programs are filling up, that there are a lot more people applying into them. The competition for those spots is very high, and that nurse practitioners were graduating more every year to help try and meet that need. I think is when we're looking at and talking about quality, when we're looking at outcomes, usually the studies are comparing nurse practitioner outcomes to physician outcomes. The quality studies are showing that in every study that's been done, nurse practitioner quality outcomes in terms of patient care management and the medical outcomes of whether it's controlling their diabetes, their high blood pressure, getting their screenings done, taking care of the patients, that nurse practitioners are as good or better than their physician counterparts in every study. Nurse practitioners have higher patient satisfaction. Oftentimes they spend a little more time with the patient. They come at it as a perspective of a nurse, where they're sitting down, listening to the patient. What are their individual needs? What are the barriers to care? Here are the options that you have for your care, but what's going to work best with you of those options? Is there something you really don't want to do or a reason why you don't want to do that? Let me help you find something that will work for you and your option. And that's very much the nursing perspective that we bring as providers, very different from our physician counterparts.
Yeah, and there's lots of different places where nurses work. So I see a nurse practitioner who is in a family practice, but it's Jean Cox, and I've only seen Jean for years because it's really been wellness stuff. I haven't been sick. I just check in for my cholesterol, which is usually pretty terrible, and have her tell me about my weight, which is usually pretty terrible, and stuff like that. But we have a wonderful relationship, and I would point out too that I have a relationship with her. It's not a transactional situation where she's providing a service because I've broken my leg or something. It's a long-term relationship, and she works for a family practice, but there are clinics who have nurse practitioners. There's nurse practitioners who have gone into their own practice.
Yes.
And this is kind of where this bill is trying to address some of the financial considerations of trying to have nurses in different situations, especially in their own practice, where it makes economic sense, which right now it does not.
So if you wanted to be a nurse practitioner on your own, you were experienced, you were able to, and particularly there are nurse practitioners who are trying to do that in Virginia, particularly in some of the rural areas that are medically underserved. You need a practice agreement, and that's very difficult if you're trying to open your own doors, trying to find a physician who doesn't know you personally, who's willing to sign on his practice agreement, who might review a few of your charts, who will agree to be your collaborator. They want to charge for that. It might be $2,000 a month, it might be $8,000, but it's extremely costly. Nurse practitioners from Medicare are only reimbursed 85% of what they reimburse the physician. in most areas. And so that makes it, in terms of a practice model, trying to keep your door open and your expenses made, much more difficult on the nurse practitioners. It would require that they see more patients than a physician counterpart in order to make ends meet to keep a practice open. It also affects even free clinics that may have funding through grants and things like that. With the practice agreement, they need to have a physician still willing to sign. An experienced nurse practitioner cannot just come in and open the doors and work in the clinic without finding a collaborating physician. I know in Fairfax County we have the Mason and Partner clinics. They are nurse practitioner run and nurse practitioner managed by two doctorally prepared nurse practitioners, Rebecca and Carrie Sutter. And one of the problems that they face in those clinics is maintaining enough physician collaborators to cover all of the faculty nurse practitioners that come in and help see patients as providers and any volunteers. So physicians are only allowed to have 6 nurse practitioners that they're in collaboration with, and in the state of Virginia. And so once they hit that mark of 6, you've got to have another collaborator. And
so this also affects, you mentioned volunteers. So even a nurse practitioner says, I will volunteer my time at a clinic. If you don't have enough supervising physicians, then you can't even bring on these volunteers, correct?
That's correct. In fact, I was personally stuck in that situation this past summer. I was between jobs, and most of the time when you're working in a job, that's who your collaborating physician was. I was working at Prosperity Primary Care. I had a collaborating physician there. My job ended, so did my collaboration agreement. And so I was 8 weeks of the summer where I was between jobs. And so I could not even volunteer in the clinics where I had worked as a student and as a volunteer in the past because I did not have a collaborating agreement, and their collaborating agreements were full. And so there were patients stacked up. There were long wait times. If they had another provider, that would have improved access to care for the vulnerable populations that they served, but it wasn't able to happen at that point in time.
And so that is what this bill, which is HB 793, HB being it is a House bill.
Correct.
So this House bill is trying to remove this barrier so that we can actually get more trained nurse practitioners in front of the patients, as you say, who are stacked up waiting for services.
Exactly. So the House Bill 793 is really aimed at removing the collaborative practice requirement for nurse practitioners who have over 1,040 hours practicing as a nurse practitioner. That's not as a student. That's after they graduated, after they're board certified, after they've finished all their clinical hours required for either their master's or their doctorate degree. And so they've come into practice, they've been practicing as nurse practitioners in a practice for 1,040 hours. At that point in time, they would be no longer required to have a practice agreement, and they would be able to see patients without that piece of paper. They would be able to go volunteer at remote area missions in Warsaw, in down by UVA, where they have the big one every year.
Well, I'm going to ask you to hold that thought, because when we come back from this break, we are going to hear more from Dr. Lora Vece about nurse practitioners and how we can help with this Bill 793. So join us after the break.
Guess what? I have some news for you. There's free food right there, junk food. You see that truck? Oh, jeez. It's a 2 Michelin star chef. All for free, ladies and gentlemen. All for free.
Here we have a panzanella with summer vegetables and pesto. Enjoy. How we doing?
So what do you got going on underneath that plate there?
This food is really about to be thrown away.
Yeah.
Is there there something wrong with this food? Where did you get it from?
From farmers markets. They put aside the ugly vegetables and the ugly fruits.
Carrot top, soft avocados. It was all food that was going to be discarded.
Even the drink you had is made from like a little bruised peach. Did it taste a little bruised?
It's good.
The average person throws away 24 pounds of food a month.
That's a lot.
Isn't that a lot? Go visit savethefood.com for more information. Thank you. Junk food time!
We're back to the Inside Scoop. Here again, your host.
Welcome back to Inside Scoop. I'm your host, Catherine Reed. Joining me tonight is Dr. Lora Vece. She is a nurse practitioner. She's also representing the Virginia Council of Nurse Practitioners as they are working to pass HB 793 during the 2018 legislative session in Richmond. Thank you so much for coming and explaining to us the details of this relationship between nurse practitioners and physicians that's actually creating a bit of a hurdle in delivering quality health care to people across the Commonwealth. You had talked about the RAM clinics, which are in Wise, Virginia.
Yep.
You said there's one on the Eastern Shore, but even doing work there, you have to have this practice agreement, correct?
Yes, in order for me to go practice at Wise, or I have been out to Warsaw, you have to have a practice agreement with a physician who says he agrees to be your collaborator while you're doing that. So in the state of Virginia, you can't practice anywhere. You can't even volunteer as an experienced nurse practitioner without that practice agreement. It becomes a detriment to volunteer work. It becomes a detriment to nurse practitioners who are trying to work with vulnerable populations in clinics that are being nurse practitioner run, nurse practitioner managed. And the research shows that if you untether your nurse practitioners so that they do not have the practice requirement, they will go places and work in environments and with populations that aren't normally taken care of by physicians. Even here in Fairfax County, we have vulnerable populations and pockets of populations who are underserved, who are medically needy, who don't have insurance or aren't covered under Medicaid, Medicare, and cannot get in to see a physician and are using the emergency rooms. And nurse practitioners have open clinics in some of those areas, and they help try and refer them into permanent medical clinics in the area. And they're seeing them, they become their medical home until they can get them into permanent clinics, like through the Mason & Partners clinics. And as nurse practitioners, we can't even do that without having a physician who's a collaborator, even though they're not seeing our patients, they're not taking care of them, they're not in any way supervising the care of them.
Well, you bring up something when you say supervising. It's not supervising. I mean, to me, it's a very hierarchical relationship that says you have a physician that technically is overseeing services being delivered by a nurse practitioner, only they're basically signing off. As you said, they might review some of your charts, but they're basically saying, I am taking responsibility for these services being delivered. And that's not collaborative, because in a collaborative situation, you're working with physicians, which says, I've seen this patient and they need different treatment, a specialist or something, and we must work together as colleagues.
Right. And I will tell you, the reality is we do work together as colleagues. If there's something that I see in a patient that is beyond my scope of experience or something I need a referral on, I might refer them to a specialist. I might talk to a physician or a nurse practitioner with more experience than me and say, hey, this is what I'm seeing. This is what the research shows. Advise me as to where you might want me to go with this, or come on and help with that patient, join the care team, help see this patient with me. That kind of relationship doesn't need to be legislated. There is no such thing as an individual practitioner in healthcare. We are all part of collaborative care teams. If you have a simple patient, their needs today, you can meet on an individual, that's one thing. If you have a complex patient with complex needs, you're going to have more people involved, so the care team will grow. And that is not something that needs to be legislated. Currently in Virginia, it's listed as collaborative practice, but it is set up as it's a collaborative practice. It's kind of loosely as to how that is set up, whether they're reviewing a few charts a year, whether they're actually, going over things, but they're not in the room with you. There's no supervision. There's no effect on quality with this. It's really more of a control measure, restricting nurse practitioner practice. In terms of nationally, what they've looked at is it's really a turf war more over who can see patients and controlling the dollars with that. It's more of an economic decision than actually quality care, because the quality is proven. The research shows again and again that nurse practitioner quality is equal to that of physicians.
So at this point, how many states have removed this?
So we have 22 states plus the District of Columbia that have full practice authority. What that means is that nurse practitioners practice under strictly the Board of Nursing. Here in Virginia, we practice under both the Board of Nursing and the Board of Medicine. There are only 5 states that require that. It means that they have no practice requirement or restrictions, and we are one of 12 states that are the most restrictive in terms of our nurse practitioners in the country. It also means that we are practiced only under the Board of Nursing. We are allowed to practice without supervision from another profession. There is no other profession where you have a doctorally prepared clinician who is supervised by another profession. And so your nurse practitioners, they're either masters or doctorally prepared, and the physicians have mandated control over it in Virginia. It doesn't make sense in terms of the research. It affects access to care for patients, as we've talked about, and it affects patient choice in terms of their ability to see who they want to see. In terms of reimbursement, the national studies are showing that nurse practitioner reimbursement is more difficult to have them reimbursed as the primary care provider in states that have practice requirements in terms of collaborative agreements or supervisory agreements.
Yeah, and that just does not seem to make any sense whatsoever. But still, so you've got the Virginia Council of Nurse Practitioners on this side, and you've got the Medical Society of Virginia on this side.
Yeah.
And so this is where it's come down to, this legislative session, with the MSV saying this is the reason we need to keep it the way it is, and the Virginia Council of Nurse Practitioners saying this is the reason we need to change this. And it all comes down to the committee.
Okay, so HB 793 is going first to the subcommittee, and then it will go to the whole committee, and then it will go on to the House floor. And there's Dr. Garrett is the chair, Delegate Garrett. He is a medical doctor, is the chair of the subcommittee, the HWI subcommittee, that will be hearing the bill. There are several subcommittee members. Some of them are leaning toward agreeing with the nurse practitioners and VCNP. Some of them are agreeing with the physicians and the MSV, or Medical Society of Virginia. Medical Society of Virginia is fighting based on quality, but as we've said, that is really not research-based.
That's not evidence-based, right?
Exactly.
Not an evidence-based argument.
They actually last weekend put up a site on the internet, and it said, I love working in care teams, Kelly NP. Well, one, Kelly NP is not a reference. But secondly, we all like working in care teams and caring physicians. They don't want to do their own social work. They don't do their own specialty. We all work in care teams. This bill is not about abolishing care teams, but about cutting off the tethers that are keeping nurse practitioners from being able to see patients who need to be cared for, of being able to keep costs down by allowing them to see patients who need to be cared for, whether that's in primary care, in private practice, in high need and vulnerable patient populations, which is of course my heart with the vulnerable populations, but to be able for them to see the patients, to provide the care so that they're not waiting in long lines, so that it's not having problems with access.
And so we recently, I guess, have had the big emergency legislation over the hospital, I think, down in Patrick Henry County, I think. Okay. So, but the reason I bring that up is because they wanted to keep this hospital from being shut down. It's in a very rural area of Virginia. Yeah. And so yes, so people recognize that there's not enough healthcare provider or healthcare services in rural parts of Virginia.
Absolutely.
So again, it makes no sense that in a place where you already have so few doctors to begin with, yes, and there's a restriction on how many nurse practitioners this physician can actually oversee, even with a practice agreement, you are further hobbling the ability for healthcare professionals to deliver services where they are most needed.
Absolutely. And that's really what this is about, is increasing access to care, keeping medical costs low, taking care of the patient when they need the care, and not when they're so sick they're in the emergency room where they're costing all the taxpayers and themselves and the insurance company more money.
You know, and I think, too, it's allowing nurse practitioners to set up practices where they live. So I have a good friend, Lori Buchwald, who is in Radford, Virginia. She's a nurse practitioner. She and a colleague have their own practice. But again, this is another hurdle she has to face, because there is an economic reality to keeping the lights on and paying the bills and, you know, and seeing patients. And you've got this additional expense, and to your point, you can't always control whether it's $2,000 a month or $8,000 a month.
Right. And, you know, like one of the doctors that I work with, he's like, it's another piece of paper that I don't need to have to deal with. He said, I have good communication with my nurse practitioners. It doesn't need to be legislated. They are professionals. They provide quality care. And I think that that's really what it's about, quality care for the patients. It shouldn't be about a turf war. It shouldn't be about who can control billing. It should be about meeting the needs of the people of Virginia, meeting the needs of the patients, and doing it in a way that it provides quality health care.
Absolutely, and we were talking a little bit before, because you work in collaboration with clinics. So my husband is the new incoming president of Neighborhood Health, and you're like, well, we refer patients to them. So you have a lot of relationships with clinics and other medical institutions and practices. It is collaborative. So what happens?
Absolutely.
So what happens when we shut off the ability to have more nurse practitioners actually sending patients who need a different kind of care to these clinics that can actually provide that? It seems to me that we are just narrowing. We're creating a bottleneck where we don't have enough people to assess what kind of care these patients need.
So, and again, that's when we go back to primary care. Who is looking at the day-to-day needs of the patient? And there is such a shortage of people who are providing that care day-to-day in the neighborhoods where it's needed for the people who need care. And that is what we want to open up with the practice agreements. Who's providing the care in the hospital with the acute care nurse practitioners? Who is actually doing it? Give those people the ability to do what they were trained to do. The goal of nurse practitioners is to be able to provide care at the level of our training, experience, and education to the best of our ability. And that is what we're asking for. One of the things that right now is we're fettered by the practice agreements. We are under both the Board of Nursing and the Board of Medicine, which is not going to be changed by this bill. We are only allowed to be in collaborative practice with a physician. You know, why can't an experienced nurse practitioner have another nurse practitioner with her and help guide and mentor that nurse practitioner? Nurse practitioners guide, mentor, and provide clinical experience for doctors. We do have doctors who come in medical school and residency and are working with nurse practitioners and learning from them. Why does a nurse practitioner need a collaborative agreement?
And that is the ultimate question that we are here to answer, Dr. Vece. When we come back from this break, we are going to talk a little bit further on how you can get involved in understanding that lobbying your elected representative, whether it's your delegate, it's your senator, but raising this idea that we need better health care delivered by nurse practitioners where we all live, whether it's suburban or it's rural or it's urban. To Dr. Vece's point, there are vulnerable populations that need this care provided without this hobbling agreement with physicians. So when we come back, we'll give you more details about HB 793.
For all the papas out there, let's stop what we're doing and take a moment to be with our kids. They can be loud moments, goofy moments, dorky moments. It doesn't really matter. Every time dads take a moment to be with their kids, it's pretty momentous. So let's all take a moment to make a moment today.
Hey, did you know that 2.4 million loving cats and dogs in shelters and rescues need our help to find a home? Go to theshelterpetproject.org and search your local shelters and rescues. Go for a cuddle with your next best friend. Adopt.
Okay, so we drowned the fire, stirred it, drowned it again, and now just feel if it's cold.
Yeah.
Cool.
Smokey just gave me a bear hug.
I know. I already posted it.
We cannot be bystanders.
We can stop to make sure someone is okay.
We can warn someone when their drink isn't safe.
And disrupt the situation.
We can
get someone the cab.
Or walk them home safely.
We can make campuses safer for our friends.
Our roommates.
Our classmates. Our fellow human beings.
We cannot be bystanders.
We can.
Intervene.
It's on us.
all of us.
Learn how and take the pledge at itsonus.org.
When it comes to saving money,
Boss,
what? Don't act like a baby.
Oh, it's like they're having their own little meeting.
This is so humiliating.
Be the boss.
I'm the boss.
What the?
Power nap. You were saying.
And make a budget.
Let's get to work.
Need a little help?
Stacy, read back the notes.
I can't read. What's it say?
Create a personalized savings plan and get other tools and tips.
We can share.
You obviously didn't go to business school.
At feedthepig.org.
We're back to the Inside Scoop. Here again, your host.
Welcome back to Inside Scoop. I'm your host, Catherine Reed. Tonight I'm talking with Dr. Lora Vece. She is a nurse practitioner, and tonight she is here on behalf of the Virginia Council of Nurse Practitioners talking about HB 793, which is before our House of Delegates. It is a bill that is basically asking to remove the supervising physician requirement for nurse practitioners in order to be able to practice out where they are needed. So let's talk about some of the things that you have encountered. You said your training is basically in rural health.
Well, actually, my training has been with primary care and vulnerable populations. I've actually been a nurse for 33 years. I have a master's degree as a nurse educator. I have taught full-time. I have practiced the whole time in there, and I have, for the last 2 years, been a certified family nurse practitioner, board certified, and I have a doctorate degree as a family nurse practitioner. So with a doctorate degree, I have more clinical hours experience coming into that than even the master's degree program. My work while I was working on my doctoral was with the Mason and Partner clinics, where I saw vulnerable populations. My doctoral work itself was based on integrating oral health into primary care, where I worked on integrating oral health for vulnerable populations. And the most at risk are, of course, our children and our elderly with chronic disease. And so working on improving provider knowledge, whether that was physicians, PAs, nurse practitioners, or your nurses and who were seeing the patients day to day. How to care for oral health, how to assess oral problems, and how to do fluoride varnish with our children. In fact, I went into 4 or 5 different practices now in the state where I have trained physicians, PAs, nurses, and nurse practitioners on how to do fluoride varnish and basic oral health teaching. Why are we doing oral health in primary care? Well, first of all, most children don't see the dentist until 3 to 5 years of age.
That's true.
And the recommendation is they start at a year, but the reality is they're often not seeing a dentist until they're almost in kindergarten. So if someone isn't talking to them about toothbrushing, isn't getting the fluoride on those teeth when they're young, they're developing a lot of caries. And caries are on the, which is dental cavities, are on the rise again in the United States. They were actually down for a while. And so primary care is starting to look at that and saying, how can we intervene? Because we're the ones that are seeing them for those well checkups. We're the ones giving them their shots. We're the ones that can reach the children. We're also the ones doing the chronic disease management for our elderly with diabetes and different chronic diseases who are also at risk for oral health issues related to either their medication side effects or the fact of the disease itself, because we know oral health is very systemic related. And so I'm also doing a lot of teaching related to oral health problems and how to prevent them for our diabetic patients, for our patients who are on multiple blood pressure and CHF medications, for our elderly who are frail, who have dry mouth syndrome and things like that. And how do you help take care of them in primary care? Because many of them, they're not seeing the dentist for a different reason. They don't have any dental coverage.
Right.
It's expensive. They're not going unless they're in pain. How can I help improve their situation? And that's really how nurse practitioners look at the patient populations. How can we improve their overall health to meet their needs? In this area, I've seen a lot of patients with Lyme, and so I've seen that beautiful rash Erythema migrans is the name of it, multiple times. The practice where I work, several of the physicians have come up, come look at this rash, do you think it's Lyme? And so, I have helped work with that and help with care of patients with the rash. What do you do next? How are they taken care of? Pulling up standards of care for that, and helping implement care for Lyme disease. It's huge in this area. It's really growing. My day-to-day practice, 2 days a week, I am seeing pediatric patients at Pediatric Care of Northern Virginia. It's a lot of fun, and the kids are wonderful. A lot of patient teaching involved as a nurse practitioner, parent education, working on not just, the cold, the cough, the flu, the whatever else the kids are coming in with, constipation, et cetera. I mean, they have all kinds of issues. It runs the whole gamut. Some are much more complex, but also, really working on teaching for wellness and habits across the lifespan. And then I also work 2 days a week at the community service boards, where I provide primary care for patients who have psychological issues and are being seen there, and that's through the Mason and Partner clinics. And for these patients, it's a lot of chronic disease management. It's a lot of working with their back pains or their urinary tract infections or whatever else is going on with them, so that they're taken care of and don't end up back in the emergency room, and helping bridge them then when they become insured into a permanent primary care practice.
Well, you hit on several things in all of that too. Lyme disease tends to be sort of endemic in certain areas of Virginia. So when you have, like in Loudoun County, for instance, and I have had friends that have had difficulty having their Lyme disease diagnosed. So the fact of the matter is, you're becoming a subject matter expert simply by the patients that you see that have health issues simply because of where they are living. That's just a for instance. My daughter also asked me, why isn't dental care and vision care covered in health insurance? But it's not. So if you don't have, this is 31 years old, it's kind of like, so why isn't it covered, dental care and vision care? But it's not. So if you don't have that coverage, you're not seeking treatment for that. And your point about oral health and the fact that people, unless they have, tremendous pain, they are not seeking preventative care. And so, problems with the mouth have a tendency to create lots of other problems. In finding dentists, I know is hard. Neighborhood Health actually has dentists in that clinic.
Yes, they do.
But I think they're one of the few clinics that does.
That's correct, but it is changing. We are starting to see dentists and hygienists move into some of the clinics. There is a bill, I don't know the number on it right now, that is going up. The Virginia Oral Health Coalition is sponsoring it to try and improve oral health coverage, particularly for adults. That's really tough to find in this state.
I can imagine.
One of the things with dental coverage is it's usually through your employer, so when people retire, they're often not covered. And, so this becomes a big issue in terms of that. Fortunately, with children who do qualify for Medicaid, Medicaid does cover their oral health. But like I said, even if they're covered, they're often not seeing a dentist to begin with. And so really what's important as a healthcare provider is looking at the overall patient. What are the needs that are affecting their ability to be healthy? And approaching those needs. And as a nurse practitioner, that's my training.
And so talking about vulnerable populations, that is going to vary again by where you happen to live as to who that vulnerable population is.
Absolutely.
In Northern Virginia, we have a lot of new Americans. We have a lot of immigrants to this area.
Yep.
And so I can imagine that language becomes a barrier, transportation is a barrier, and culture must be a barrier too, as far as how we approach healthcare and how healthcare was approached wherever they came from.
In terms of culture, it's very difficult in terms of looking at healthy weights, particularly with some cultures in our groups. Some of the Latino Hispanic cultures view a heavy infant, a heavy child as a sign of health and wealth, which is wonderful, especially from where they come from. But in the United States, it might mean that they're eating a lot of junk food, very overweight, and we're setting them up for diabetes and hypertension as they get older. And we don't want that to happen. And so we're trying to educate and intervene with that. A lot of the new Americans who are immigrants to this area came from places where they boiled their water. One of the things I found in talking to them, especially as I started oral health training, was they were coming here and they were either spending the little money they had on buying bottled water for their home, or they were boiling the water in their home because they didn't know that our tap water was safe. Not only safe, it has fluoride, helps prevent cavities. I had one of them almost kiss me when I said, you don't have to be boiling your tap water. You don't have to spend any of the money you have in your food budget on bottled water. And so that was a big deal for that population. Wow. Not something that we thought of ahead of time. It was something that we found as I was doing my doctoral work. And so part of our education with those new patients is, you know, and those families, because we do it as a family group, and they come in and say, hey, you know, in where you live, the city water is safe. You don't have to boil it. You don't have to spend money in your home for water.
Well, I'm just intrigued by this, the fact that you are saying that you treat them as a family group. It's not just a patient with a problem. It's like you're looking at someone in the family and basically explaining how everybody needs to understand food and oral hygiene and how safe the tap water is. And I don't know too many practices that approach it that way.
Well, I think that's very much a nursing perspective, and I think that's kind of one of the things that sets us as nurse practitioners apart. When I look at a patient, it's not just the patient, it's the diabetic I saw this morning. It was a patient with diabetes, and he said, you know, I'm really struggling with my diet because, you know, I don't do the cooking, my wife does. And my question is, okay, can we get your wife in? Can we discuss diet and discuss diet education with you and your wife so you can be a team together? Because his numbers on his glucose are never going to improve if we can't reach that level. The other thing is when we're talking about healthy eating and long-term outcomes, if we can improve the healthy diet in that home, we can also decrease the diabetes risk for type 2 diabetes for the children being raised in that home. So this is a much bigger impact than affecting one patient.
It is so much more holistic too. I mean, this is so much more than I've got a toothache or an ache or a pain. You know, there's a lot of people who believe what we eat is all about wellness, that we are what we eat. And for good or for bad, we are what we eat. Diabetics struggle with it, but so do parents of children, especially in places where there are food deserts. And too many people are relying on a lot of food with preservatives, and that comes from food banks. Yeah. Honestly, people who need food assistance are often eating food that's not fresh. It's not wholesome, and it's not really adding to their wellness.
Okay, so let me tell you another story. This is about a patient who came to see me at the Mason & Partner Clinic. He was a gentleman, probably in his late 50s. He had come over from Iran for a medical conference in Chicago. He was here on a visa, and he got a phone call from his wife. They had moved 4 times with their 4 children. Please don't come home. Al-Qaeda has been here, and they are looking to kill you. They were looking to kill him because he was teaching science to junior high and high school aged girls back home, and boys as well, but because he was teaching the girls. And so he was not to come back home. We found out he was an infectious disease doctor and a nutrition specialist back in Iran. He had walked an hour to come to our clinic, and he came to see me, and he said to me, his first words out of his mouth were, my hands are peeling and I think I have a nutritional deficit. Well, most people in this country, if they said that, I would look at them and go, okay, and then I might go over, and I said, all right, tell me why you think you have a nutritional deficit. Well, he had run out of money. He was eating less than 1 meal a day. He hadn't eaten protein in days. He had enough money that he had covered his housing, and he was trying to figure out how to be on asylum here. So at the clinic, we connected him to a food bank. We gave him emergency food supply because we were in coordination with the Family Services in Fairfax. We got him into Family Services so he could get housing, he could get into a food bank, and we said, okay, we're gonna see you again. Actually, one of the nurse practitioners took him and bought him some groceries that day.
That is amazing, Laura. That is amazing. You know, and when we come back, we are going to hear more from Dr. Lora Vece, who is a nurse practitioner.
Here, kitty, kitty. Here, kitty, kitty, kitty. Here, kitty, kitty.
You'd think it would be easy to tell which kids have trouble with their eyesight. But that's not always the case. Even though 1 in 4 children may have a vision problem, eye doctors tell us the symptoms aren't always so obvious. We do know that 80% of all childhood learning is visual. And without good vision, kids can have trouble learning to read. and may fall behind in school. For clues on how to spot the real-life signs of childhood vision problems and what parents can do, visit checkyearly.com. A public service message from the Vision Council of America and Reading is Fundamental.
Checking your fantasy league?
Nah, just my 401k statement.
Nice. Where'd you find the money for that?
I've just been saving a little every month.
I can't seem to save anything.
Well, what about all this? What about the money you're spending?
What money? It's gone before I can get my hands on it.
I got a pizza for a Todd.
Hey, can somebody spot me?
When it comes to financial stability, don't get left behind.
It's 547.
Get tools and tips for saving at feedthepig.org.
We're back to the Inside Scoop. Here again, your host.
Welcome back to Inside Scoop. I'm your host, Catherine Reed, and joining me tonight is Dr. Lora Vece. She is a nurse practitioner, and she's here tonight on behalf of the Virginia Council of Nurse Practitioners as they are looking to get HB 793 passed during our 2018 legislative session. I appreciate so much you being here. And the story you just told about this gentleman who came to see your practice and the questions you asked just reminded me that it's about treating a whole person and not just a rash, and that asking questions and understanding their circumstances leads you to all kinds of understanding about how to meet the needs of that patient. And tell me I'm wrong, but it seems to me that is just how nurses and nurse practitioners approach it differently.
And I think that would be true. I think one of the things you need to understand is that there's only a small percentage of health that is affected by any drug I prescribe to you or any treatment I do today for your acute problem. Most of your health is affected by your lifestyle choices, your ability to get what you need, and what we call the social determinants of health, which is your socioeconomic status, your ability to get food from a grocery store or fresh produce. We talked about food deserts. Yeah. And a lot of those characteristics really affect your health. We talked about where you live. Well, your zip code really does determine your average lifespan. And if you look on United States maps, you can look and you can see where the vulnerable populations are. You can see 2 miles, 3 miles across, particularly in Richmond. There's some places where you can have a 10 or 20-year difference in the average lifespan based on where you live. And so we really need to look at an individual, not just from the medical point of view of here's their family history, here's their current numbers, here's the medications they're on, here's their diagnosis. We need to take a closer look at what's really going on in that patient environment. You know, what is affecting their ability to make diet choices? What is affecting their ability to take medications? Oftentimes as nurse practitioners, we're looking at patients, we're prescribing off the $4 list. There's a real good reason for that. If a patient can afford their medication, they're more likely to take it. Yeah. They're also usually tried and true. We know the side effects, we know what to watch out for, and it's a much less burden on the patient and the family. So that's a great starting place, instead of starting with the latest, greatest that the drug rep is bringing around.
Well, you know, let's talk about pharmacology and the detriment of overprescribing. I mean, we have, the whole country has an issue with the opioid epidemic, but part of that too is relying on pharmacology over lifestyle changes, diet, exercise, things that people can do to strengthen their back muscles and the things that they can do to manage their pain, not just taking a drug. I mean,
absolutely. In fact, taking a drug should not be our first line for most things, especially when we're talking about chronic back pain, chronic disease, chronic problems. We need to look at what are the things we can change to improve that. When we're looking at particularly pain management and the opioid epidemic, a lot of those patients are put on opioids for a short-term pain issue, and then the pain does not go away totally. They're left on those opioids. They develop a habit. They develop an addiction to it. They're taken off the prescription. They go look for it on the streets because we haven't bridged them into a better way of taking care of themselves. We haven't empowered them well. And so the goal would be that, you know, we take care of these patients. In fact, some of the research coming out right now, especially the research relating to kids and pediatrics and surgery and stuff, shows that some of our non-steroidal anti-inflammatories are as effective or better effective at controlling pain than some of the opioids. We need to look at exercise and strengthening, alternative ways to control pain. We need to look at what the patient's current lifestyle is, what are ways we can improve them. We need to have goals based on improving their function, not necessarily on making them pain-free.
That's so true.
You know, we need to look at their function not only in terms of their ability to move, but their ability to think, their ability to work, and not just look at, are you pain-free today?
Yeah, and I mean, that is just a different holistic approach to how you treat a patient. Again, people are more than their diagnosis. They're the sum total of how they eat, whether they exercise. I heard something that sitting is the new smoking. You may have heard that too. But it's just getting people to understand that a healthy lifestyle involves so much more than just going to your physician and getting a prescription, to your point, so that you're pain-free.
Absolutely.
The goal should be is to feel healthy, to feel like that you can function in a way that, whether it's your work or playing with your kids or doing simple household chores, these should be goals. That's what our goals for our health should be.
And absolutely. And you talked about sitting as the new smoking. A sedentary lifestyle is extremely dangerous for your health. As we're looking at the research coming out and we're looking at lifestyle, that's really where the power is. And one of the things I think you will see with nurse practitioners and our training and the way we approach things is we're really big on looking at preventative health. We're really big at looking at lifestyle teaching, at helping the patient set realistic goals. You're not going to lose and make it successful if I tell you you're going to lose 50 pounds over the year. But if I say, okay, what are the things that are preventing you from losing weight right now? What are the things, can you pick one or two things you're willing to work at? Come see me again, let's see how those affected, let's go to the next step. Let's start with it. Are you ready to talk about quitting smoking? Okay, you're not ready to do that right now. I want you to think about it. What's preventing you? Why aren't you ready? Come talk to me again about that. When you're ready, I can help. So we're really looking at what's called motivational interviewing in terms of how we talk to patients. You can't just have a patient come in and tell them what they should do. That is never going to work. My plan is not their plan. It has to be their plan. I can suggest and say, these are the things I'm concerned about. What do you want to do? What do you want to work on? That's going to be my successful change, my patient who is able to take control of their own health, who is able to move themselves forward. Because it's really not me doing the work, it has to be them.
You know, and this to me is such a logical, when you say it that way, it's such a logical way to approach healthcare in the main. And especially for every person in our population who deserves to have this kind of wellness care and holistic health care before they become ill or before they become sick. You know, we need to have people getting this motivational, deep listening, let's work on a plan sort of health care. And so I'm suggesting to our viewers that they really need to take an interest in how we get more nurse practitioners in front of more people and remove this burden of having this practice authority arrangement so that more Virginians are getting the kind of health care you just described. Where would people find information on that?
Okay, well, there's two ways they can do that. The first one that I would suggest is there is a Care for Virginia website. And to find that, it's Care for VA, all one word, no spaces. If you try and Google it the other way, you won't pull it up. So it's careforva.com. If you go on that, a website will pull up. It will give you some information on nurse practitioners. It will give you some information on HB 793. And if you click on Take Action, it will lead you to a site where you can page down and write your legislator. You'll pick whether you're a physician, a nurse practitioner, or a lay person. And when you click on that, there's a preloaded letter which tells you a little bit about HB 23, what we're trying to do. You can add your own comments. If you fill in your name and your address in there, and you click send, it will send a letter to your legislator supporting nurse practitioners, nurse practitioner practice, so that we can help to get rid of this restrictive practice of practice agreements, which is preventing us from being able to see patients and treat them as we are trained board certified and educated to do.
Yeah, and I think that makes that should be something everyone cares about, simply because regardless of whether people actually see a nurse practitioner, they should care whether their neighbors, their children in their local school systems, and the people that they live among and see every day have adequate access to good care. I mean, that's what makes a healthy community. And in the end, we want healthy communities, and having affordable, accessible health care is a huge part of that.
Absolutely, and that's really what this is about. This is about opening up patient access to providers who are qualified, willing, and able to give the care, the quality health care that they need.
And so I will also put in a plug for the fact that legislators do care. People are like, oh, but what's an email? But oh, why should I call? Because especially if you are a constituent of that legislator, whether it's a delegate or a senator, they keep track in the offices. They know exactly how many people called and said 793. They make a note of it. They know how many emails they got. They know how many people wrote a letter, or how many people showed up to the office, who actually came to the office and said, I'm here to talk to my delegate's David Bulova, about this bill and the fact that I want him to support removing this restriction. So careforva.com is the place where people can go to find these resources and this information.
Absolutely.
And I do think it's important for people to understand that when you help to provide greater access to health care for everybody in our communities, we all benefit in the end.
Absolutely, because it decreases the total cost and the burden on the taxpayers when people are cared for in the best way, when they need it, where they need it.
And our current structure, I think if I recall, you said 5 states, only 5 states have this kind of structure.
So our current structure involves a joint board of nursing and medicine. There's only 5 states that have that. Virginia is one of 12 states that has the most restrictive practice requirements in the country. There are 22 states, plus the District of Columbia, that nurse practitioners have full practice authority. What that means is they practice without supervision of any other profession to the extent of their training, education, and experience. Here in Virginia, we're not allowed to do that. Here in Virginia, we're tethered by practice agreements. This bill would stop practice agreements for experienced NPs. It would also let providers, such as experienced nurse practitioners, provide the practice agreement for a new practitioner. So it wouldn't just have to be a physician, because we're running short on physicians willing to do that. They are hampered partly by their number, they're hampered by their location, they're hampered by their insurance with this, and some of them just don't want to do it.
Right.
And usually if they do want to do it, they want to know that person personally. So if you're coming to the state, you've been a nurse practitioner for 20 years, you've had your own practice in another state with full practice authority, you are going to have a really hard time getting a doctor for a collaborative agreement in Virginia, even though you have been providing excellent patient care for years.
Yeah, and so that's the thing. I think that nurse practitioners mentoring other nurse practitioners sounds like a wonderful thing, in my opinion. Yeah. So I'm going to encourage our viewers to really get involved in this. Go to, tell us the website again, is
careforva, all one word, .com.
And that's where you're going to find information about HB 793. Reach out to your delegate, reach out to your senator, tell them that you are interested in healthier communities, and part of providing healthier communities is making quality health care more accessible to more people across the Commonwealth of Virginia. Thank you so much, Dr. Lora Vece, for joining me tonight. This has been illuminating and very educational. I wish you the best in getting this bill passed.
Thank you very much.